presentation, so it was kind of nebulous as what this really represented right here. But it's pertinent for the differential. So, to continue on, she also had confusion with this. This did get a little bit better, but there was no, to kind of summarize these next couple points, there was no real migrainous symptoms to this. So it's not unilateral, it wasn't really necessarily throbbing, no photophobia, no autonomic symptoms, nothing like that, no aura, prodrome, nothing like that. She didn't really, relate the Goldschlager to the trigger, but that was kind of about the only thing new to her, so I figure it's the gold. And she denied any trauma or anything like that. Now, she was still weak, still fatigued. She felt like it was harder to walk, and memory and concentration difficulties were still there. And she was definitely having trouble sleeping due to her pain. No recent changes to medication, nothing else to speak of. However, this was her current pain regimen. A little ibuprofen, at least 8 pills multiple times a day. A little Tylenol, at least 8 extra strength a day. Throw a little naproxen, and a little tramadol. So these helped her headache, and it turns out she has actually taken a decent amount of this. This is a little bit of her normal, but pretty close to what she normally takes anyways. She kind of just stopped these things. It actually, lo and behold, gave her a little gastritis while she increased these. And she usually is used to these things, though, for her arthritis that she has. This is also her other meds. Nothing too incredible. And nothing changed. So her exam, really nothing super remarkable in the vital signs. She didn't really look at any distress or anything like that. Oriented very easily. Language was fine. Everything was fine. No papilledema, which is fine. Neck was tender to palpation in the posterior area. Cardiovascular was regular. General was very good. Neurological exam was completely intact. So we really had a very complete, normal neurological exam in her. She just was a little tired and had tender neck. So we got an MRI with that finding. And as you notice, the very obvious normality of this. So really, we didn't find that little spot. That was red as possible blood. Her MRI looked beautiful. This is our second patient. Similar story, a 58-year-old woman who previously had tension-type headaches, again, much more infrequent than our first one. And after she was singing in her community choir, she developed the same sort of thing, rapid onset, worst headache of her life. She became very confused with this, couldn't really remember why she was there, what was going on, very disturbing to her. A headache was everywhere, nonstop, throbbing at times, 10 out of 10, and then got a little bit better over the time it took her to get in to see us. No nausea, vomiting, again, no real things that would really point to a migraine-like attack. Very different. In the emergency room, she actually had a very good workup, and we'll get it, and I'll say that just a little bit. But one of the things to point out with this one is that she was very worried about that, and that's one of the classic things you see about this, and that's something not to ignore in this, is that kind of when you go through your clinical gestalt of who looks ill and who doesn't, these people are ill. These people look bad, and they feel bad, and they get very scared. So the ER did a pretty thorough workup. So she had an MRI of her spine, her head, an MRA. All of those were unremarkable except for a little spinal disease. She had a lumbar puncture, which was very nice and clean. And then ER, they gave her some composine, some saline, and then the only critique I have is the fear set. So one thing to take away, and anybody who's worked in the headache clinic can tell you, never use that drug. Ever.
Why?
Causes headaches, rebounds. Not effective. Not effective. So her past medical history of the headaches I mentioned, then the other major thing that is also playing a role in here, that we feel is playing a role in here in pathophysiology, is metabolic syndrome, and of course the hypertension, hyperlipidemia goes well with this. One of the biggest things, not for pun, is the central adiposity. So waist circumference, we feel, is actually one of the highest predictors of people's likeliness to become, or to get headaches, come down with recurrent headaches, be prone to headaches, have these things, and we feel some of this is actually related to a baseline higher inflammation, inflammatory factors that are circulating. And it doesn't, again, this circumference seems to kind of predate these things before the hyperlipidemia and everything else. I just really like that picture. I thought that was the most impressive central adiposity imaginable. He's pretty proud of it too. So Thunderclap, what is it? So it has a couple different definitions. This is sort of the most recent smattering of ideas that came out of the last conference that was here. Some of these slides are based on information that was presented there. It's a little bit different than the definition from the International Head Society. So high intensity, abrupt onset. So usually peaks within 1 minute, 1 to 3 minutes. Very, very high. It originally was thought to be a limit in duration. If it lasted longer, it was probably something else. We no longer feel that's true. We feel that this is not necessarily defined by how long it lasts. People can get better, can get worse, can recur. That's not really a very reliable factor. And it is what was first noticed, and you probably all remember from medical school, subarachnoid hemorrhage. The rapid onset, worst headache of your life, out of nowhere sort of thing, maybe high blood pressure, all those sorts of things you think of with burst aneurysms. So, and it still is much that way. So this is, I would call it by definition, emergency to rule out things of that nature and other problems that need to be treated. It can definitely, what's interesting is vascular causes like subarachnoid hemorrhage, but also many non-vascular causes too are associated with it. And there's also this sort of overlap of what people are referring to as primary thunderclap headaches as well as other rare headaches, such as provoked headaches that you see with exertion or orgasm. So the differential is quite large, actually. How small this is, I'm not going to go through all of it. The main thing to note is that there's definitely a lot of vascular problems, but one of the things I want to point out is masses, both neoplastic and not. Sinusitis is actually not that uncommon. Retroclival hematomas, interesting, and infections, of course, meningitis. MI, there's actually several documentations of MI presenting as thunderclap headache. And then, of course, the other things that you can kind of think of, activated sclerosis, pheochromocytoma, so other things. So it is not limited to intracranial pathology by any stretch of imagination. And I will talk on the pathophysiology of this to kind of explain why that probably is.
So do you think it's clear from the MI association, which is the chicken and which is the egg? Could the MI be secondary to thunderclap headache?
Absolutely, absolutely. You know, somebody who's going to be prone to an MI, you know, it's sort of, I remember when I was in medical school, I remember hearing about elderly people dying from black widow bites. And it wasn't because of the black widow bite, it was the pain that gave them an MI. And I think that that's definitely a possibility. The case reports were the other way around.
Right.
But absolutely, it's possible. Absolutely. This is actually from our own website, so it's just our little definition on our own website of a subarachnoid hemorrhage. And so everybody can probably point out the blood here occupying the subarachnoid space. Pretty easy to see. If you see that, you kind of have a good idea what's going on here. So it turns out 11 to 33% of the thunderclap headaches are due to subarachnoid hemorrhages. So a pretty good chunk of these folks. And you'll notice throughout my talk that there's going to be wide ranges of numbers here, and that's because there isn't a great, there's not really great data in all these. A lot of these don't come to the attention of us, so I apologize for that, but I did my best. So 11 to 33%, 70% of these have only a headache. So they do have a subarachnoid hemorrhage, and they don't have anything else, just a headache. And half of those are thunderclap headaches. And so, really, I think if you feel that somebody had this type of onset, it's a subarachnoid rule-out. Really, that should be the highest on the list, and emergently so. So how to look this up? Again, I'll go back to this in a little bit, and there's definitely some debate about that, so it's another reason I'll revisit it. There's some suggestion that in tertiary centers, especially ones with third-generation CT scanners, as well as experienced neuroradiologists, that the CT non-contrast is as good or even maybe even better than the lumbar puncture. That is definitely a controversial and new thing to say. So the kind of rule I would suggest to most is that CT without contrast, if it's negative, needs the lumbar puncture. And that's kind of the rule that most people are going by these days. Now, the lumbar puncture is not very sensitive in less than 12 hours. So blood can get down to the lumbar region in less than that. But we feel that the sensitivity is really maximal around that time. The problem is that the sensitivity gets lower as time goes on as well. So you have a window around 12 hours to 24 hours where the sensitivity is the highest for the LP. So if it's negative before that, you're going to have to do it again to make sure. So 85% of the bleeds are due to ruptured aneurysms. And most people feel pretty strongly that if you actually do have subarachnoid hemorrhage, you need some type of angiography to kind of find out aneurysm and other things. So this is from our friends at Northwest Radiology, and it's a very nice demonstration of a unruptured aneurysm with coiling that they're doing. And here's another unruptured one. Why I bring this up is there's a term that is thrown called a sentinel headache. So there's thought that there could be early bleeding, early stretch, causing thunderclap headache before it bursts. And so 43% of ruptured had a sentinel, what was thought to be a sentinel headache, days or weeks prior to that. Now keep in mind these are retrospective, so recall bias is definitely going to be playing a role in that. So nobody knows really the prospective data. There are some smaller studies that have looked at that, and it's much lower than 43%. But because of this, people are very nervous about this, and how much to do for angiography to look for these things is still up for debate. I thought that was kind of scary. So other intracranial hemorrhages also can present. They make up about 5–10%. Carotid dissection, quite often, has associated headache. Whether it is a thunderclap or not you probably all know from your own experience of seeing these, but you definitely usually see head and neck pain with these. This is a nice picture. If it's kind of fuzzy and I'm blown up, but this is actually the dissection right here. They're repairing. So down towards the body, up towards the head, internal, external, bulb, bypass in place, and there's your little dissection flap. This is things. So as I can point out here, that shouldn't be here, and this is getting squished. The brain's going up. There you go. You can also imagine, when you think about pathology here, that it's probably going to rearrange from the CSF flow as well. Giant cell arteritis sometimes presents. Again, it's an underlying inflammatory mechanism that people aren't really quite clear of, different than cerebral vasculitis by definition. And I'll talk a little more about that. But the other thing that this picture points out, you've got your temporal, your middle meningeal and those the temporal arteries coming up in there. And meningitis is also on our list. Sinusitis is going to be on our list. Dental abscesses. I mean, anything you can think of that can cause acute head and neck pain can present as thunderclap. But of course, we're not as worried as we are about some of these other things. Tumors. The tumors that do or do not bleed. So this is in the pituitary. Here's the third ventricle. Here's the cerebellum. This is another wonderful website you haven't seen. It's MyPACS. So like the PACSystem.net. It's a thing that neuroradiology residents have been putting together. It's a collection of cases and such with imaging, great imaging. You guys haven't checked that out. So cerebellum. Meningitis. It seems like every fall we see many children that die from preventable meningitis, and also college kids. Yeah, it's tragic, very very much so. But to appreciate here, this is T1 pre-contrast, this is post-contrast, and that is abnormal. Sinusitis. So this is the sphenoid sinus. It is full. As a little side note, almost all chronic sinuses that present to ENT are actually turned out to be migraines. It's very interesting. Dr. Marinova can talk more about that, but it's actually impressive how many actually turn out to be migraines and have nothing to do with the sinuses. So it makes sense that the opposite would be true as well. MI. So definitely something to keep in the back of your head as you're looking these people up, because it obviously is an emergency as well. But I think we've all experienced on both ends of the spectrum that we think this is neurological and it actually turns out to be the heart. Other people think it's heart and actually turns out to be neurological. So we get plenty of strokes that present with chest pain, plenty of chest pain that's actually a stroke. Just like this. This should be on the list for that as well.
I was told of a case the other day by a Baltimore physician of a patient who developed severe occipital headache as the pain of her MI. That's
exactly what this is. Yeah, that's exactly what this is. That's exactly what that is. So good. So hypertensive crisis hypertensive encephalopathy, or what we now are more commonly referring to as reversible posterior leukoencephalopathy syndrome, or the old acronym of PRESS. People use both these days. This was originally something noted by radiologists that we've now kind of come to recognize many more clinical entities that look like this on MRI. But it seems to be part of the spectrum in the vascular problems that we have that cause the underlying problem we have that causes thunderclap headache. So keep that in the back of your mind, and we'll get back to that. Which leads me to the reversible vasoconstriction syndrome. So what is this? Well, it's exactly what it says, and these are some images. Now, these images, I'm sure at least this one, you guys have probably seen something very similar at Harborview with stroke. So this could easily represent maybe a clot that gets taken out. You got a little blushing over here because things got ischemic, all that sort of thing. Very classic for that. That's not what this is. They did intraarterial nimodipine for this. That's the difference between these two. There was not a clot. This was just vasoconstriction. Same thing over here. Very interesting. So it is likely what we are now referring to as reversible vasoconstriction syndrome. What we used to refer to as many other things, called Fleming, migraine vasospasm, or crash migraine with stroke, benign angiopathy, thunderclap with vasospasm, all these things. Postpartum, that's another big one. And even PRES may or may not fit into this. It's kind of, we'll see. Drug-induced cerebral vasoconstriction, I don't think there's any dearth of information on that from Harborview with our cocaine and methamphetamine population. So the prevalence is really not well known. Again, I put up these ranges just to demonstrate that point. So when we review literature, ages 13 to 70, that's either everybody or we just don't know, right? And the male-female ratio of 2 to 10 to 1, I mean, it's ridiculous numbers. I don't think it's just very well known. It's just not very well recognized. Because how many people with headaches are you getting angio on? In 2004, though, Dr. Ducros from Paris actually did a prospective study of 113 patients who presented with thunderclap headache. So 53% were found to be secondary causes. So when I say reversible vasoconstriction and vasospasm, I'm not talking about trauma. I'm not talking about things that you really can kind of put your finger on. These are something else that is an underlying pathology, probably related to too much sympathetic drive, either globally or the nerves around for the blood vessels controlling them reacting too much to sympathetic drive. So this is what they found, that it was a vascular cause in about 50% of 50 patients, 44%. Those are kind of the rundowns. And so what they found is that this reversible vasoconstriction was more prominent than anything else. And they felt that they had another 5 that didn't quite meet criteria on imaging, but were likely, given now that everything else being negative, likely going to be this reversible vasoconstriction syndrome. And so what they gathered from that is it's quite underreported, and that we probably just need a lot more diligence to look for this, to really kind of to go for that. And there's a reason why. Is that there is a clinical presentation, and then there are problems that people develop. So 94% have a recurrence within days to 4 weeks. Most people have a trigger. So most people are going to have exertion or stress or a drug or something that, when you think about a trigger, think about something that increases the sympathetic drive. So, or vasoconstriction. Drugs could do that. So Sudafed can be, all those things. And only a headache in 75%. Some of them, focal deficits are also quite common too, and that's where people probably were missing the ball, is people with just headaches. Because if you see a focal deficit, of course you're going to be worried about something focal, and you're going to do maybe a little bit more thorough workup. But without that, you might not. And seizures actually can present as this as well. So the other thing that's just amazingly consistent is the response to nimodipine, or even other calcium channel blockers. Just it's quite uncanny, actually. It's not at this point a definition, but it seems to be consistent. So here's one of the triggers. So the little boy, little girl, they're both naked. The one on top says, "Okay, we took off our clothes. I got on top of you. How long before it starts to feel good?" And the girl says, "I don't know, but I have a headache already." So I know that I've seen a few orgasm-induced headaches. And we see that not that uncommon, actually, in the ER. I've seen quite a few of those. That's likely one of these triggers for thunderclap headache. As you notice, this is a pretty general list. So it's really going to be hard to say there's any one. What you find in these patients, though, is they will know their trigger. They will know the trigger. So people will come in and say, it's this, it's orgasm, it's exercise, it's whatever, hard defecation, it's something, and it is quite often very reproducible. So this is why we care. Why we care to diagnose this appropriately and treat it beforehand is because the complications. So you're constricting blood vessels, and even though it's not something by itself, it's not embolus and things like that, it does cause damage. So these is kind of a rundown of the things that can happen from it. And it's not inconsequential. Again, are these numbers really that accurate? These are probably people that are presenting with focal deficits, that are getting the angio, that are having the follow-up, and all those things. So we're probably missing more than this. So the workup. Again, I refer back to this notion of the CT being enough. I think that if you're like anything, Dr. Mara had just a great comment a couple Tuesday mornings ago when somebody's PCR came back negative. And she said, if it's negative, that doesn't mean anything. If you really think your clinical suspicion is right, that's really the important thing. Something, yes, that could be helpful. Just because the CT is negative, you should not be done thinking about subarachnoid hemorrhage. Might make it lower, certainly, but it can be up there. So the older CTs that did the larger prospective studies found about 5% were CT negative with a positive lumbar puncture and positive angiography. We feel we're better than that now, but that's about it. We talked about the lumbar puncture. So if the LP is negative, the CT is negative, you're feeling pretty good about all this, you should remember, don't forget the heart, don't forget about the non-neurological causes, inflammation and other things. The other thing that I want to mention is when you do an LP on these people, how do you tell the difference between traumatic tap and subarachnoid blood? Very difficult, right? So all the studies that have looked at trying to tell the difference by sight, bad, not very reliable. So you can do spectroscopy, but only a small percentage of centers do it, and it doesn't come back very quickly.
Alex, I was just going to comment that the CT sensitivity drops off pretty precipitously with time.
Absolutely, absolutely. Thank you for pointing that out. Same with the LP sensitivity. Once you get a day out or so, it really starts to drop out. And as soon as you get 2 days out, forget it.
I don't know about forgetting it. We had a case a few years ago where it was about a week or so. There were no red cells.
More controversy about where to go from there. So I think that we have easy access to MRI. We like it. It makes us feel good. I think that's a good place to start. It's going to catch a lot of these other problems, these tumors that I'm talking about, all these other things that can present as Thunderclap. It's going to catch a lot of those. One of the biggest areas of controversy after that is what to do to look at the blood vessels. So it turns out that people that are prone to this, any contrast agent, especially the iodinated, but any can actually induce it, and especially conventional angiography. That's been known for a long time to induce vasospasm. That's nothing new. And so somebody that you think might be at risk for this, are you really going to induce it, take the risk of inducing it even more? And you can almost make that same argument for LP. It's also not the healthiest thing to drop the intracranial pressure a little bit with taking out fluid, but we feel the risks outweigh the benefits, benefits outweigh the risks in these people. So one of the things you can do is MRA time of flight. Now, we probably all have had different experience with this, but I've seen some just beautiful MRA time of flight. I don't think it rules out aneurysm by itself, but you can see some great stuff. So if you're looking for big occlusions, dissections, things like that, and then also considering MRV for these folks. Dopplers, nice, easy, non-invasive way to look for these things. You can also follow flows. You get a real-time idea. You get your resistive indexes. You can watch those change with treatment. That's not done, but I would love to see that study sometime. It could be a nice way to screen these people. Because in general, the vasoconstriction that we do see is generally right around the circle of Willis. That tends to be it. So in general, you got to take everybody as they come and really discuss the risks and benefits with these things, about how aggressive you're going to be for conventional angiography or family history, it turns out, is actually very important when you're thinking about this diagnostic workup, and mainly in regards to subarachnoid hemorrhage. So if they've had one first-degree relative with a possible subarachnoid hemorrhage, the odds ratio goes up to about almost twice as likely for them than the average population without that. If they have two first-degree relatives, that's very, very scary. So as we all remember from our, polycystic kidney disease and all the other things, there definitely seems to be a genetic predisposition for the aneurysms. So this is kind of what Now, there's not, unfortunately, I can't speak a lot about this because there's just not that much in there. But this is the main predominant theory with this: is that there's an overdrive of sympathetics, there's a constriction that happens, and that is dysfunctional. It's too much. Now, whether the nerves are responding too sensitive to something, or the underlying drive is too high, I can't tell you. It's probably both, and it's probably different in each case. So, for instance, pheochromocytoma, that's probably a pretty strong drive. Cocaine, pretty strong drive. Some of these other people, singing in a choir, that probably shouldn't be a sympathetic drive that would give most of us a problem. But in our patient, it was. So we think vasospasm leading to ischemia, and then you can actually see edema, infarct, bleeding, and you also have your pain. And this is where we try and make a little bit of a connection with PRESS and reversible posterior loop encephalopathy. There is an idea that has been put forth in literature in the headache world that is the constriction that happens first. The damage then results, and it's the dilation secondary to the damage. So these are heavily dilated in areas that are ischemic. And that's why we see this dilation. And that's really the underlying dysfunction, not the ability for the blood vessel to constrict it to begin with, but that it constricted too much to begin with. And we're seeing the after effects. I can't back that up, though. I can just quote expert commentary. So this is the treatment. First, obviously, you got to look for these bad things. But if you don't find them, if you think this is just one of these trigger things, you're not dealing with a lot of other focal problems and things like that, you really, you can feel pretty good about that. But once we're done with that, then it really comes down, what are you going to do? Well, calcium channel blockers are the mainstay. Now, nimodipine is the drug that's been used the most, and it is the one that's studied. I don't really know exactly how that is. I know Tom over at Harborview is very consistent about how nimodipine doesn't really drop your blood pressure, but it dilates the cerebral blood vessels very well. That being said, I've dropped people's blood pressure with nimodipine, so I take that with a grain of salt, although Tom is probably right, as it usually is. Nimodipine is something that we usually go to when we definitely have any focal neurological symptoms, because we're worried about ischemia. And that being said, it is incredibly expensive, and it's a Q4-hour drug, so it can be hard to do. So actually, a lot of people will do other things. We use verapamil. We've also used amlodipine. And the question about how long you're going to treat these people for is a good one. So if these are, a trigger that they're going to re-experience, it might be lifelong. Somebody who has hypertension at baseline, this might not be calcium channel blockers, probably a good drug for them at baseline then. Beta blockers may have a role if calcium channel blockers, for whatever reason, are not available or are not useful. So keep that in mind, because again, we were talking about sympathetic drive here. And then, of course, avoiding triggers. Avoid daily headaches. And this is where we come back to what the ER did. So that's one of the classic things we see over and over again is you have a headache. It's very bad. So, of course, you want to take something. Of course, you want to take anything at that point in time. And you keep on taking it, and you just keep on getting rebounds. You keep on taking it, you keep on getting rebounds, and you keep on going. How that affects the actual vasospasm, I can't tell you, but I can definitely tell you it's not good for quality of life. Possibly they might need lifelong treatment. It just depends on your patient and how severe you think this is. Other people we treat episodically. So we just had a gentleman who only got it with exercise. So he's experimenting with indomethacin and propranolol before he exercises to see if one of those, he doesn't want to do the propranolol because he wants to exercise hard. So he's going to try a little indomethacin before he exercises hard. We'll see. So sometimes if you really have such an exquisite trigger like that, you can treat beforehand. So both of our patients did very well. We did verapamil for both. They both had amazing turnaround of their pain within 48 hours. Their confusion, their sleeplessness, all that was gone. So they did very well. Now these are people that will probably keep on these medications for at least a couple months. One of the sort of general gestalts we use is kind of let things calm down. I think that you probably hear that too in the epilepsy world as well. And for some reason, 2 to 3 months always seems to come up. I don't have a good reason why, but it seems to work. So in summary, I'd like to say that thunderclap headache, very bad headache, quickly reaches its peak intensity. It really is quite like a thunderclap. And it's uncanny how many people will say it's by far the worst headache of my life, or it's by far the worst pain of my life. Women who have given birth say this is much worse. It's very consistent about how bad this is. It's a hallmark of it and how fast it comes on. it is an emergency because of all of the things it could represent. Don't forget about the non-neurological causes. Don't forget about your cocaine, your overdoses, all those things we always see at Harborview and other places. Again, you know, people can be using Ritalin. You might not be aware of Sudafed, things like that. And really, the calcium channel blocker is the cornerstone, and in particular nimodipine, which even can be done intra-arterial if you need to be. So this is my little parting word from a pro-war protester. Any questions? No questions? It's a very controversial subject.
Your second lady, in addition to her headache, had sounded like she had significant memory loss. She said she couldn't remember anything.
So
I don't know how long it went on, but I
yeah.
wonder, has there ever been any overlap with transient global amnesia?
That's an excellent question. I think that you'd have to really go back. You know, my experience of like my N of 2 or so with transient global amnesia did not have headaches. I think that, again, you know, we're not angioing these people, so it's really hard to say because that's part of our definition. But I wonder, and it'd be also, you know, I kind of posed a similar question about press to Dr. Becker. And, you know, if you think you have this, what about just trying calcium channel blockers for these people and just seeing if they get better? Again, I don't think it's going to give you a diagnosis, but if you can help, it would be powerful, it would be useful.
So to diagnose the reversible vasospasm, you didn't go ahead and get angiograms on your 2 patients.
No, that's by clinical. Yeah, the Thunderclap headache with this, it's becoming. Well, probably Dr. Marinova can speak to this, but it's really becoming so. It's become so recognized as so reproducible and so classic that people are kind of shying away from getting angio on everybody. It's a controversial subject, though. Some people are angioing everybody.
You can't make the diagnosis of reversible
No,
cerebral
you're right.
vasoconstriction without angiograph. I mean, that's
You're absolutely right.
So you just treated a Thunderclap headache with calcium channel blockers.
Yeah, I'm not saying that they absolutely had. No, I'm sorry that was a. Yeah, I'm not saying that. I'm just saying that the reversible spasm is part of the Thunderclap presentation.
And I think to Dr. Bird's point, I think you might also have to think about other types of vasculitis if this lady has memory issues. You know, often the differential is a little bit tricky between RCBS and a more long-standing CNS vasculitis or vasculitis.
Yeah, and
vasculitis with CNS.
So in these patients, clinically, they responded to calcium channel blockers. Within 2 days, the confusion, headaches, everything was gone. So, you know, the question always is, and this is an excellent question, do you go to doing the angio or not? And, you know, the experts, you know, Dodig is one of the top experts in this syndrome, and he feels that, yes, if you have something without explanation ongoing, maybe you should go, but you should also realize that, unfortunately, the angio can cause worsening vasospasm and worsening symptoms. So, you know, where do you go? Do you know, clinically? So to me, you know, what I have been doing MRI, MRA, those are normal. And even before they are done, you know, I would proceed with the calcium channel blockers. If they respond clinically, do you want to go to, you know, another, you know, expensive and potentially, you know, risky test? You know, you might not. The general feeling is.
What about the CS? I mean, that's just not a. I'm not sure that's a defined or an accepted way to make the diagnosis of the response to calcium channel blocker, at least not.
No.
Thunderclap headache response. Yeah. So.
To make the diagnosis of RCBS, it's a definition based on angiography.
No, yes.
Right.
And with an LP
right.
CSF findings that are
absent
of pleocytosis.
Right.
So I think I think my presentation is confusing. I'm not saying that all Thunderclap headaches or even our patients definitely had reversible vasospasm. It is suggested by their presentation that we see, when we do see this presentation often, it's suggested that that's part of it, but it's not clear at all because, again, we're not angioing all these people. Now, there is this syndrome of a primary Thunderclap headache, which is basically a Thunderclap headache without a cause. And then there's overlap probably with people that have a cause like effort or, you know, stress or things like that. But you're absolutely right. No, this is not, we cannot define our patients as vasospasm. We don't know. We just say that Thunderclap headache and treat them as such. that it depends on how many strokes. So in the study that I showed from Paris, it was small but a good chunk. I think it was 3 or 4 patients.
Does that help distinguish?
Well, I mean, our
6%
CVS cases
in all.
or they cannot. They can have hemorrhagic strokes. They
Yeah.
have subarachnoid hemorrhage. A percentage of them will have ischemic strokes. So it'll be diffusion positive. But that's.
What about TPD? Do you ever read those?
I'm not aware of any literature that's been used.
Yeah, I couldn't find any literature either. I thought it was sounds like a great idea, but I haven't seen it either. I think that the thing is
I mean, it's very difficult to differentiate an acute subarachnoid from a reversible cerebral vasoconstriction without the LP.
Yeah.
And in fact, I had followed some patients in clinic where they had a patient presented with a thunderclap headache. They got a CT that was negative, say 12 hours after onset. They did not do an LP. And then they come back months later and they want to know what the diagnosis is. And you almost have to start the workup over again. It's a very difficult thing to say.
Yeah, and I think that you bring up an excellent point about the vasculitis. That is always something, I think it's sort of like a sinus venous thrombus. I mean, these are things that can not necessarily present with stroke. They can not necessarily present with a stroke on the MRI or things like that, but...
So you have vasculitis on one side of it as being part of the differential with RCBS, but on the other side you have an acute subarachnoid hemorrhage.
Sure.
And both of them can look like RCBS depending on the clinical scenario. With vasculitis, you've got to think about a longer time frame, long-standing headaches, cognitive changes, memory problems.
Yeah. In regards to our patients, they were pretty rapid, and it was really associated with the pain. And that's, again, what we see with the diagnosis of thunderclap headache. So, again, I don't think that anybody has enough data to say that thunderclap headache is by definition a reversible vasospasm. It just seems like we're trying to go that route eventually, trying to see. We're trying to do that, but again, we have to angiograph everybody with a thunderclap headache, and nobody's doing that. So I don't know, maybe somebody...
So now, actually, Dr. Dodick from Mayo Clinic, they have been doing angio, and that's how they found that many of these patients who presented with a thunderclap had otherwise negative workup would end up having the reversible vasospasm of the angios. And the question comes, do you go that route in all the patients or not? And it's a very controversial question, whether you should go to angio if you have all the other workup negative. And I think it depends.
I would think if you have a suspicion of subarachnoid hemorrhage, you have to pursue it to angiography. And I'm not sure. I just think that that's sort of the standard.
What does neurosurgery think? Yeah. Yeah.
You know what? I agree with Einstein. Absolutely. In a situation when you're concerned for the possible subarachnoid hemorrhage. But I actually want to ask you another question. Let's say like the first patient has this tiny dot in the blood.
Yeah.
So how you can justify that this is the cause of the...
I didn't
have
know.
the same thing with like, let's say, small tumor and things like that. How to make this connection?
It's not causation. It's association. Yeah. So I can't. And this is one of the inherent problems with headaches, and I think any pain. Why one person damages a nerve and doesn't get any pain, and the next person has something debilitating and horrible. Why one person gets a headache and not is just, who knows? Where does pain actually start in the pathway is not known. So absolutely, who knows? There are people who have amazing hydrocephalus who don't have a headache. They come in with diplopia. Not common, but you can see it. And why other people, their very first presentation is headache before anything else, I don't know. So it's clear that there are some areas that are more sensitive, like the meninges. But clearly, a tumor in the third ventricle, how does that cause a headache? I don't know. I think that when you see like pituitary apoplexy, that's blood or infarct, I think you can kind of think about direct damage. But no, I don't have a good reason as why, how to connect all these things for headache. It's just an association.
But this is a pretty common situation.
Yeah.
In terms of the world of the investigators or researchers for the headache, is anybody trying to find the way how actually to make this?
Yeah, actually, Dr. Ellenbogen approached me with the idea that he has done extensive literature search, has actually done the data on how many people with incidental findings of, let's say, pituitary tumors, present with headaches. And, you can't say actually, that's what he pointed out to me, even though we don't usually do surgeries, it's really difficult to be able to do, pineal cyst is very common, right? It's very difficult to do, surgeries of these patients, and he doesn't in the majority, Then the question comes, do they or not cause headaches? How can you prove it or disprove it, and what would be the mechanism? No one has a clue. No one has done any studies, any reviews, and he's really interested. He wants to get some fellows to do the data. Then I get even further problems that we do imaging more than ever. We used to think that incidental findings are really incidental, very rare. He claims that up to 20% of people that present, will have abnormalities, let's say in the pineal gland, much more common than we ever appreciated. And then what do we do with all this data? It's obviously much more complicated. But the whole point, of this was that you should take patients, obviously very seriously with their complaints, and try to treat them to the best of what is likely the pathophysiology, and get the best treatment. So I think what is kind of tragic is I see a lot of patients who started with Thunderclap but then get into daily headaches. These continue for weeks to months to years, and yet these are potentially treatable patients. And I have seen some that have gone to the angio, and angio was negative, and that's even the question. I mean, if it's something reversible, can it come and go? Do you have to do it exactly at the time you have the data?
Well, I was just saying, I mean, the risk of an angiogram in a 40 or 50-year-old otherwise healthy person is extremely low.
Yeah.
And the risk of, and the downside of missing a ruptured subarachnoid hemorrhage is, as neurosurgery would agree, is potentially catastrophic. So you've got to be very careful, I think, about not pursuing these.
I completely agree. And so I think you bring up a good point. One is to be vigilant about other causes that could be underlying it, not to exclude vasculitis just because they got better or something like that, but also to really...
I'm not talking about excluding vasculitis, I'm talking about excluding subarachnoid.
Right, but also to, if you're clinical, even though CT is negative, even if you know, whatever it is, if you feel a clinical suspicion is still high enough, go on to do whatever you think you need to really work out.
But that does seem like you would end up doing a lot more angios than, especially someone who presents with a trigger, which just because someone has a thunderclap headache that comes on during intercourse doesn't mean that that's not as appropriate.
Absolutely.
That is a pretty big category.
Oh, no, I think we've all, I don't know if I should say all, but I think we have seen subarachnoid bleeds during anything surgical.
If we've had a negative CT and they've had a negative LP, then you don't have to pursue the
And
end.
these patients had negatives.
But not all these, it wasn't clear to me that that was the case.
There was a case that they had negatives, CT negative, LP negative, MRI negative, MRA negative, MRE. So you go to angio, and all of these patients, I would say, probably not. So, yeah, but there might be.
But again, if there's a strong family history or something else, it's really being eaten that way. Good. All right, thank you very much. Oh, hey, how's it doing?
Are you going to introduce the Tony?
No, it's good. I'd rather have people. Well, the bonus of controversial is everybody talks amongst themselves. I just sit back and watch.
Oh, you are prepared.
Hi, how are you, Tony?
I knew I was going to.
Tony, good, how are you? I haven't seen you, but you've been busy?
Somebody clinically has a
Yeah. Would be great.
This is, I'm going to give out.
We're going to set you up here.
Our AD guy is right behind you.
There's financial disclosures here, residents and the residents tonight can have financial disclosures. This is set for the recording, and your lecture is posted to the website for
I am going to go show. Are you going to?
Thank you.
Usual 3-day visit.
Yeah,
have some fun little connections you're going to make? Bump into some old friends?
Oh, yeah.
Isn't that good? I love that one. I know.
Does Yale have
You should see how appropriate my path was. I think you and I and